everyone. I'm Shraddha Kamdar, the Deputy Editor at Femina Magazine. And today for our conversation and an interesting panel discussion, we have 5 great doctors with us. We have Dr. Parul Katiyar, Co-Medical Director in the Art Facility Clinics in Delhi, Dr. Priya Kannan, IVF Lab Director, Karba Raksham Bigai Fertility Center in Chennai, Dr. Kundan Ingle, Director, Nirmiti Clinic, Center for Assisted Reproduction and Endoscopy in Pune, Dr. Purnima Durga, Medical Director and Chief Fertility Consultant at MOM IVF and Research Center in Hyderabad, and Dr. Babita Panda, Managing Director and Chief IVF Consultant at Future Fertility IVF Center in Bhubaneswar. They have all joined us for an informative panel discussion on the causes of infertility and the treatments that are available. We all know that when couples look to become parents, they have their own attempts. But when these attempts do not succeed, we also know that they are at a loss. They don't know what's going on and they feel like they are victims. And there is this constant thought that they have that why us? Why us? So today we have experts here who suggest that they should look for medical assistance as the way forward. Bharat Serums and Vaccines Limited, one of the fastest growing biopharmaceutical companies in India, presents this discussion on assisted fertility as part of the ongoing IVF Awareness Week. For over 50 years now, Bharat Serums and Vaccines has used its scientific resources to develop a range of biological, biotech, and pharmaceutical products to treat various types of diseases, especially in the IVF, women's health, and critical care space, and continues to contribute to preserve, protect, and enhance the quality of life. So in this discussion presented by Bharat Serums and Vaccines Limited, we intend to look at the causes of infertility and the treatment options available for couples who want to experience the joy of parenthood. So thank you, doctors. Thank you for being here with us and taking out your precious time to let our viewers know what's the way forward for them. So my first question here would be for Dr. Priya. Dr. Priya, can you shed some light on infertility among women and what are the causes?
As we say, infertility is basically, if you're looking at the causes, it can be divided into having causes that are from the female partner, causes from the male partner, and there is a huge chunk as well, which we call it the unexplained infertility, which means we do not know yet why that reason is there, or it does not confirm to both these male or the female side. Mm-hmm. But as the scientific advances are going on, a lot of these unexplained infertility, we are trying to find a reason. It's found so that it's from 30% it's now come to 20%. So for example, as a rule of thumb, we say that 40% of the reasons for infertility could be on the female factors, mm-hmm. and 40% male factors, and about 20% unexplained infertility. Well, we're keeping aside the male infertility aside, I'll just say a few words about the female factors of infertility. Mm-hmm. The female factor of infertility, we have 3 major factors, or not factors, parts that we need to look at. One is the egg. These are the 3 major parts where if there is a problem, it can be a cause of infertility. Number 1, the egg. When the egg is a problem in having ovulation, that is, the growth of the egg is not happening every month. That is why they might have irregular cycles and stuff like that. That is one. Or when they have very less number of eggs in them, that is what we call them as hyporesponders or poor responders at the very later age. Mostly it occurs at a later age group, but nowadays we see that it can happen sometimes in the younger age group as well. Any problem that can happen with the egg can cause infertility. Another one is the fallopian tube. Fallopian tube is that part of the body which connects which is an extension of the uterus, and that is what picks up the eggs from the ovary, and that is where the sperm meets the egg. So when there is a blockage of the tube or any infection of the tube or anything that is something wrong with the tube, then it can also be a cause of infertility. The third, again, is the uterus, very important organ as well. Sometimes there can be like fibroids or any other anatomical disorders, or something like the endometrium has got it's thin endometrium because of infection, or various other factors which can create a problem in the uterus, can also be a cause of infertility. These are all the major anatomical parts which we can say and then segregate for easy explanation to the patient. That's how we just explain to them the egg, tube, or the uterus. There's another major problem that is also we are seeing more often nowadays, is the female sexual dysfunction as well. That is, they have this fear of having intercourse. And that sort of female dysfunction, which also we seem to see a lot more nowadays when we are able to counsel them and go ahead with them. But yes, these I would probably say in a larger way the 4 reasons where the female factor infertility can occur.
Okay, thank you. That's very informative, and you've explained it in a way where all of us can understand where these things can go wrong and where to pinpoint. So, coming to the male infertility or fertility part, Dr. Kundan, like we mentioned, and Dr. Priya also said that mostly it is always either assumed or it is thought of as female infertility, and therefore, very often, even between couples, the male infertility part is either left undiscussed or untouched. So, can you tell us a little more about that aspect, and also the aspect of how you deal with patients, with couples who are facing a loss at accepting that it could be a fertility issue with the male?
Okay. I think very rightly mentioned about that there was a social taboo couple of in fact a decade ago, that there used to be always that, okay, I don't have a problem. That's always the sentence from husband. And probably it was always considered that the factor or cause of infertility is on the female side only. And today also still sometimes we do get patients like that they are investigated only for the female factors, and not a single test has been done for the husband. So we do come across such patients still because of the social taboo which is sitting behind it. But I think if we sit with the couple and we explain them that, almost as Priya mentioned, that yes, now a male factor which contributes into infertility is in the range of almost 40%, and that's quite huge. And if we look at the graph of incidence of male factor infertility, it is on increasing side rather than a steady or decreasing side.
All right.
So we have to understand that 2 decades ago we used to always say that male factor is 10, 15, 20%, and now we are talking about almost double, which is 40%. So we do have a lot of cases, in fact, which we call it as a combined factor infertility, where we have in a single couple, we have a female factor and as well as a male factor. So it's no more like only individual factors are present in any single couple. So I think now we need to deal with those all because of probably change of lifestyle. You can say there are lots of habits increase or sudden increase in the addiction, like habits of smoking, alcohol, tobacco, chewing. I think all those things are coming up so rampantly in last decade, and I think we do see such change in the graph. And I think counseling is the most important, which I always feel. And in fact, the simplest thing, okay, for a male factor to diagnose, we have hardly 1 or 2 couple of tests by which you can completely rule out. So in fact, we always counsel the couple that first we investigate a husband, because once this factor is ruled out, that's a major chunk is gone, and now only we can focus on the female factor. So in fact, husband semen analysis, or maybe for any other reason, those other special tests which are there, we can advise and rule out his problem, and then we go for a female factor evaluation.
Okay, thank you, because you put it so simply, and you also gave us this contrast on what it was a decade back and what it is now. That is quite an eye opener, which I believe that at least the couples out there would have no trouble in believing and in no trouble in accepting that it could be a human body problem with either of the genders. So thank you for that answer. And Dr. Parul, I have a question for you that couples often have this doubt or because firstly the acceptance part has to come in, that why isn't any of their effort paying off. So they often wonder when is the right time when they should go out and seek medical help. So according to you and according to your experience, at what stage should they go out and ask for help?
See, if technically, if a couple has been actively trying to get pregnant for a year, and yet they have not been able to achieve a pregnancy, so this is the time when they are recommended to seek advice and consult a doctor, just to rule out if there is any other problem which might be causing a delay in their ability to get pregnant. So 1 year of inability to get pregnant is defined as subfertility or infertility, and therefore in those cases we recommend them to seek a consultation and get themselves investigated. In older couples or in couples where the woman is more than 35 years of age, especially the female age is very important. In those couples, what we recommend is that they should get themselves investigated earlier than later, which means if there is a inability to get pregnant for even 6 months of active trying, it is good that they get themselves investigated. This is important to do so because women have a limited reproductive life, and as the age advances, their fertility is declining. So the probability of them getting pregnant is reducing, and secondly, we want that if there is a problem, it can be identified and tackled in a very timely manner. So therefore, in couples who are older, they should seek help if there is no pregnancy within 6 months. And of course, for any couple where they know that there is a dysfunction or a previous history which might be leading to infertility or subfertility, probably they can even get themselves tested earlier than later.
In case of those who are older than 35 or a little closer to 40, is there any advice for those kinds of couples, or should they also, like, is there any time frame that you might be able to share?
Yeah, that's what I said. So if in a couple where the female, especially the female age is more, it is very important that they seek consultation earlier. So 6 months is the recommended timeline. Of course, for a 40-year-old female, this can even be shortened because there we know that their fertility is anyhow going to be quite low. So it is better that they get themselves investigated, do the basic workup to see what is her current ovarian reserve, see if there is another factor, what is the male factor like. So it will be good that any woman who is older, even if they have just started trying, there is no harm in getting themselves investigated to know for sure that there is no problem which will, decrease their chances of getting pregnant and lead to more waste of time. So 6 months is the recommended time duration for these couples.
Dr. Purnima, I was asking you
options available.
the different types of treatments or options that are available once a couple knows that they are facing some form of infertility.
Basically, all patients who come us are emotionally, like they are very anxious, emotionally low. So the first thing is obviously, as Dr. Kundan sir explained, it's the counseling, which is very, very important. And with the advanced technology now, today we are celebrating the World IVF Day. As we all know, the first IVF baby was born after so many attempts of retrieving the egg, and after so many attempts, the success rate has come. But now with the advanced technology, we have lot more options available for the couples. But the most important thing is approaching the doctor, exploring the treatment options, what they have. That is more important. As we already discussed, the time, age limit, when to approach a doctor. So we all discussed, no, that's very, very important. Elderly couple need to approach early to the fertility clinic or to the gynecologist early to know the treatment options available. So the options available are again depends upon mostly the cause of infertility, as Dr. Priya has already explained to us. There are so many causes of infertility: female, male factor, combined factor, as Dr. Kundan explained. So the treatment options mostly depend upon the cause of infertility, duration of infertility, how long the couple are infertile. The most and not the least most important thing is age of the female. As Dr. Parul explained, it's the reproductive potential of the woman is limited when comparative to the male. So we have to take consideration all these factors: the personal history of the couple, the age of the couple, the cause of infertility, duration of infertility, any previous surgeries on the ovary like endometriosis or cyst surgery. Taking all this into consideration, then you can counsel the patient regarding the treatment options available and the success rates accordingly. So what are the treatment options we have? So we have a range of treatment options, basically from simple interventions to the advanced interventions like IVF. So the simple interventions is if a woman is not ovulating properly, that means she's having irregular cycles, or ovulations are not proper. So we can just start with simple medications which helps her to ovulate regularly, and that is the basic treatment which we give in our day-to-day practice. The first simple treatment is helping the woman with medications and helping her to ovulate properly. And the first option is having a time. If the husband semen analysis, everything is normal, tubes are good, then you can go for a timely intercourse cycles. That is ovulation induction and timely intercourse. That's what we see. So the first simple treatment is helping with us with some drugs and asking them to have a proper timed intercourse. Then comes the next option. Some people may need laparoscopy or hysteroscopy. Surgical intervention might be needed in some couples where like probably PCO, where polycystic ovaries, where we need to drill the ovaries, or endometriosis, where we need to excise. It depends on the cause of infertility. Sometimes they may need surgical interventions as well. Some tuber blocks can be cleared by surgical intervention. So any uterine abnormalities, if they have, those can be like septum or something. So there is a role of surgical intervention as well in these types of infertility. And the other simple ART procedure which we do is IUI. IUI is intrauterine insemination, where in cases where there is a mild decrease in the sperm count or motilities, IUI will help them, like any previous treatment failure said, we are giving repeated ovulation inductions and timed intercourse, still there is no pregnancy. There are some indications for IUI where you can go with a simple procedure where we just take out the husband's sperm, wash it, increase the motility of sperm, and inject into the womb of the female. So that's a simpler ART technique. And the last but not the least is we have IVF ICSI, like where in cases of advanced age of the female, prolonged infertility, severe male sperm counts, severe endometriosis cases, tubal blocks, in all these cases you have the advanced techniques like IVF and ICSI. Previously, we have improved our success rates very much in our ART cycles. Previously, the success rates per cycle used to be around 20 to 25%. With the advent of new technology, freezing, a lot of technology has come. Now we are able to give around 50% success rate per cycles. So it's like how early you approach a doctor, the better the success rates. Younger the age, better the success rates. Ultimately, what I want to tell is age of the female is the most important thing which helps in getting the better success rates.
Right. Thank you, Dr. Purnima. This was really informative and on how they can go ahead. And thank you for introducing the treatment called IUI. Dr. Babita, my question to you is that, for example, a patient opts for a patient can benefit from an IUI and they opt for it, and it doesn't succeed. So what is the number? How many times can a patient go through IUI before they are then suggested that this might not work and you have to go for the more advanced IVF?
Yeah.
Basically, we've already discussed. So if says younger age group less than 35 and we do a ultrasound and see that her ovarian reserve is fine, husband's mills is having erectile dysfunction. They cannot have normal intercourse and we are going for IUI. So those cases we can go for 4 to 5 cycles of IUI because each cycle of IUI gives a success rate of around 15 to 15 max 20%. So if that is the reason, only for that we are going, so we can go up to 5 to 6 cycles easily. It says young patient. But if says a case of endometriosis, female patient with endometriosis of severe grade 4 endometriosis with lots of adhesion and where the tube and ovarian relationship is disturbed, there is a lot of adhesion in the pelvis. So those cases, actually recommendation is according to female age, if she is a younger age group patient, then we can try for 1 or 2 cycle maximum. But if the age is more than 35, she is a case of severe grade of endometriosis, definitely IVF would be a better option rather than exhausting her ovaries and eggs in IUI cycles.
All right. Thank you. And I have one difficult question. I mean, I believe it would be a very difficult question from the end of the patient to it's to all of you. Doctor, what happens when after they go through the entire IVF and it fails? Before we go on to the risk, I want to put in this factor so that it's just out there for them to hear. What if the cycle fails? We know we've just heard that the success rate has gone up from about 25 to 30% to 50%, about 50% now, but still there are chances that the cycle fails. So at that point, psychologically, physically, and otherwise, how what can the patient do and how can you help the patient?
Basically, before any ART procedure, be it IUI, be it IVF, they need a good counseling. Already all the panelists have focused that counseling is a major part, first and foremost treatment option in case of infertility. What we do a group counseling for all IVF patients and again separate individual counseling. What is the exact success rate will be for that particular couple, depending on her age, her ovarian status, her male factor problem, and her uterine condition. So those things has to be discussed thoroughly, and we have to be a sympathetic attitude. That is very important. Like they may be positive or may be negative, but if we get a positive response from outside, many times they seek for any answer, and we answer their questions and queries. And each step has to be explained to them in each visit they come for. Sometimes hydrosalpinx, it's a major cause of IVF failure. Sometimes the first cycle fails. We have to look for a thorough ultrasound or a laparoscopy. Somehow we have to rule out the presence of unhealthy or hydrosalpinx that can be a reason behind being after giving good blastocyst also the cycle fails. So those things has to be discussed in detail. Because sometimes when we do stimulation and patient hear that she is having 20, 25 follicles, their expectation goes up. But when we go for pickup and we see we are getting 20, 25 eggs, but the quality is not up to marks, particularly obese PCOS patients, we get very poor quality oocytes that results in poor quality embryo and that negative result. And always a frozen embryo transfer option has to be opted for this group of patients. In PCOD patients, goes for implantation failure in spite of good embryos, then we have to look for some hysteroscopy or endometrial biopsy to rule out endometrial tuberculosis. It can be treated accordingly. So those are the patients, like if one cycle fails, we have to go through the file, go through the patient record thoroughly, and what can be done best for her with good counseling. That would be our main.
Can I contribute something?
Yes, please. It was
when Dr. Babita has beautifully explained about all the things that they can improvise on the clinical side to when the cycle fails. We as embryologists, we get to see the eggs and the sperm straight under the microscope. So whenever a case fails, then the extra information will come from the embryology lab as to if there was any notable problems that we saw in the eggs or in the sperms or in the embryos or how they were dividing and stuff like that. That small information, which it's not a small information, we just give, it's probably 1/3 of the information we're giving to the patient, but then that plays a huge part in their success, or like, how we can improve on them at a later date. So that is a very vital part of information that we share in every case after every IVF cycle or ICSI cycle, whichever ART cycle that we do, that helps in counseling the patient on what could have gone wrong, how we can probably, if there is something to improve on the egg and the sperm, that would definitely help them in that way.
One more thing which I always feel that in a counseling part, we must, I mean, this is our audience which is listening, it's very important that we have to understand that any of these treatments are not 100% success with 100%, because not 100% required things we can do it by technology. So that's very important. Not every egg can give rise to a good competent embryo which can give rise to pregnancy. This is we have to understand. Even we have one cycle which might give us a better quality eggs, but another cycle which might not give us a better quality eggs. So there are in an individual monthly variations into the egg quality, and that also applies to the sperm quality. So, that's very important point we have to understand. And if we want to avoid a psychological impact of failure, I think certain points in a counseling like this, what even Babita has mentioned and Priya has mentioned, I think they are very important, that we must understand, or we must make them understand that what is IVF or what is IUI, what exactly and up to what extent these treatments are going to do the things. Yes. But they are not the technologies which are doing 100% what is required for a successful reproduction. So that is what we have to understand. And if we give that clarity, that's what make them prepare by mind that yes, this can fail me. But at the same time, if I have to discuss with my own clinician that what can be the reasons, and yes, how can we work on those to find out which is one of them the reason in her case for a failure. And because remember, the certain causes of failure are correctable, so we can correct it and then we can have a success again. There are certain causes which are non-correctable, and there are certain modifications into this kind of treatment which is going to help them to achieve a success. So, one failure is not the end of the road. That's very important. Okay, we in fact undergoing one IVF cycle gives you much better, clear ideas about the gamete qualities and lot many things. So in fact,
yes, actually, I do agree with Dr. Kundan sir. I'm about to tell that first cycle is always a trial cycle, I believe, because we get a lot of information from the first cycle, how to go about in the second cycle. So Dr. Kundan sir explained very well.
But I'll still say we should not consider the first cycle as a trial cycle. First cycle might give us good information, but it should not be taken as a trial cycle, because if done properly, a lot of these cycles result in positive pregnancies. And it will be very unfair to make the patient go through an entire cycle thinking that this is a trial cycle.
What I mean to say by tricycle is not that we are trying the cycle on the couple. What I'm trying to say is we can get the maximum success rates of 40 to 50%, but the cumulative success rates in the 2 or 3 IVF cycles is much better. That doesn't, that is like we're trying on the couple, like our treatment, we're just doing it. It's not like that. What I mean is like a lot of information.
So that is important, but sometimes the first cycle failure might help us in improving the outcomes for a second cycle.
I mean to say the same thing.
But it should not, if done properly, some things are not known to us. As Dr. Priya said, that we will not know how the egg quality is. We will not know how the embryo grows in the lab, ultimately, till we have that process ongoing. But yes, of course, many a times, this can be a recurrent phenomena in a lot of patients who will continue to have poorer eggs and poorer embryos. So my point of view is that any failure, whenever we should sit down as a team, the embryologist, the patient and the doctor, discuss that outcome and see what could be changed in the next cycle and see how we can improve the results, because ultimately we can only think about improving the results. We can't still guarantee that there'll be a pregnancy in the second cycle or the third cycle. But yes, as we go ahead, the idea should be to keep improving till we are able to achieve a pregnancy.
All right. And do these couples agree to go into a second or even a third cycle almost
Yes.
immediately, or are they okay? Because there are financial constraints, I believe. So that's the reason why that's this question, that do they agree for a second or a third cycle almost immediately? And physically also, is that
Depends,
possible?
it depends upon a lot of things that a patient has to deal with. Of course, the emotional turmoil of a failure, the financial crunches that are there, and sometimes the urgency to get pregnant, And so all these things play a role in a patient deciding when they would want to go in for a second cycle. But yes, we do get patients who are prepared. If you prepare them properly, that a older woman coming to us, we know that we are not going to have a very high success rate, but cumulatively we might have a good success rate of pregnancy. So these kind of couples are very keen to continue and pursue their treatment if we give them the right head start, and they do continue, and they do take cycles in quick succession as well. Not necessarily month on month, but quick succession, maybe a month's break or something.
Okay. And what can you tell us about a few of the factors, like what kind of factors, lifestyle factors affect infertility or infertility? Might cause the fertility to go down or increase chances of infertility. What kind of lifestyle factors?
In terms of, I think lifestyle, it plays a major role for fertility, I guess. I'm sure all of the doctors here would agree that the BMI of our patients are quite high. It's quite less number of times that we see patients whose BMI is 25 and less, or around the normal range. So I guess their lifestyle does not mean just obesity, but yes, obesity is a major cause of concern for us. Almost all our patients will be putting them through some lifestyle modifications for them to lose weight. Another lifestyle, as everybody has mentioned, is the age at which they come for a treatment. So it is also a lifestyle change. People are looking more at careers and they come little late, and which is probably another deterrent that affects their fertility. And three, with all these lifestyle changes, they also go into something what we call the metabolic syndrome. So you already have women who are diabetic or pre-diabetic or with altered GTT. They already have that, or other lipid disorders, and some having even already hypertension and stuff. So the metabolic syndrome already starts kicking in because of the changes or the unhealthy lifestyle that they have been having. So all these would definitely deter, because we do know that on the molecular basis, hyperlipidemia or a lot of fat follicles in the body gives hormones which are unwanted hormones at unwanted time, leading to a lot of problems from egg production to sperm production to implantation of the embryos. So it affects the entire spectrum. So lifestyle is a major factor for us, and we do have separate counseling sessions and separate dietitians and counselors just to address the lifestyle factors of our patients.
Shraddha, I think it's very important that if we look at the last 3-4 decades, I think everybody will agree that there is something called, for the audience, it is like something called as an ovarian reserve, which is a capacity of our ovary to give you kind of a set of number of eggs.
Yes.
So that reserve, which we have started seeing, that it is significantly decreasing into especially our Asian women. I think Priya will agree that we are seeing this increasing incidence. Like even 15 years back, we used to see hardly 8 or 10% patients having such a significant low reserve, where we struggle in getting their sufficient number of eggs and even the quality. And now we see this incidence has gone almost in the range of 40-50%, and which is very, very significantly increased. And if you look at the literature, quite a lot, other than surgical intervention, but quite a lot, this decrease of ovarian reserve is contributed because of the lifestyle. the way we are eating, the way we are having kind of, inorganic foods, what we call it as, which is grown up in fertilizers, probably, which are not supposed to be, healthy fertilizers for us. So there are a lot many things. Obesity, as Priya rightly mentioned, is associated with also this kind of problems. And also at the same time, we are seeing this in husbands also. That is on the male side, because we see a lot of increase in the diabetes, a lot of increase in the obesity in that group. We are seeing a lot of increase in their habits like smoking and tobacco chewing, which is affecting their sperm quality, which is affecting their sperm production, and ultimately contributing increased incidence of male infertility. So I think lifestyle, yes, I think it's a major role probably. And that's what we saw in COVID era time, when we started having, kind of a change in the lifestyle. We started seeing a lot of patients of our own who attended our infertility OPD started conceiving spontaneously. So, that's a good proof for our patients that understand that what kind of life we are living and how much drastic change we need to do in our lifestyle, because that's going to give us a natural fertility back to us. So I think that's very important point. And Arshada, it's a very important point you brought up. I think it's an important message to be given to the population.
Yeah, I just want to add, sir, like I have a PhD student who had done a paper comparing the alcohol effect of alcohol, tobacco chewing, and smoking. 3 factors in the males that contributes to sperm count decrease. And we did the study for 5 years and published a paper also. So it's shown that among these 3, tobacco chewing has the highest impact on the sperm quality.
Yes.
Male who chew tobacco at least 8 to 10 packs in a day for 5 years, sperm count can decrease up to 50%. Alcohol had the minimal effect and tobacco chewing had the maximal effect. So that has to be there in the male counseling part. And very importantly, the stress. They're so nowadays, the lifestyle is so much, lack of sleep. Hardly they sleep for, particularly IT group of people, their timing is such, they hardly get proper sleep, no proper diet, and always the laptop will be on the lap or they will be on the mobile phones. All these are the important contributing factors. Rightly, sir said, male fertility has increased more than 40%. Diet and exercise is a must for both female and male. So those are lifestyle factors. We should have a good counseling session before we go for IVF for the couple. What should they do and what not?
A very famous sentence says that we don't live a life for a work. We work for the life.
Exactly.
So having a life is the first priority rather than having a work and a career. That is very important.
On
what Dr. Kundan had beautifully mentioned about the ovarian reserve. I think it is hugely linked. It has been we've been talking about it on the molecular side for over about 15-20 years now, from occupational hazard and everything. But then now it is out in the open, what we call the endocrine disrupting chemicals, which is found in large amounts from that is the plastics and everything, from your food to your shampoos, to your soaps, to everywhere it is there, that estrogen kinds and the endocrine disrupting chemicals. So I think the more we ingest, which is what we are doing right now, from vegetables to non-vegetarian food. So I think that we are trying to educate, but then the lifestyle is so that everybody is just quite okay with it. But that's what we're using on a daily basis. But that we've been talking about for quite some time, but I never realized that I've been talking about 15 years now, but now I never realized that in my lifetime alone, it might be a problem. But what Dr. Kundan has brought about the ovarian reserve is entirely probably could be attributed to these endocrine disrupting chemicals hugely present in our environment, in our food, everywhere.
Right. And those are things that we need to look into.
Yeah, but unfortunately, very difficult to avoid in the lifestyle that we are having now.
With reduced. That's the balance I think we are looking to strike with everyone, not just couples who are trying to become parents, but with everyone. But on that note, that we need to have a life first and then a career. I think I want to thank all of you for being here, for imparting such knowledge to our listeners and to motivating them to do the right thing, especially the factors that many of you spoke about on what can be done, how it can be done, and at the time frame in which it needs to be done. In this one factor, I think time and age do matter. And therefore, on that note, I would like to thank all of you. Thank you all for being here and for sharing this information with us.
Thank you very much.
Thank you,
Thank
Shraddha,
you very
for
much for the
excellent
interesting
discussion.
session. Yeah.
Yeah, for the excellent discussion. Thank you very much. And I think we really brought out very important points, I think, which were,
That is true.
audience has to understand and modify their life. Thank you very much on behalf of all the panelists.
Thank you.